Morning, I'm Warwick Jaffe from the Ascot Cardiology Group, and this morning I'm here with Patricia Ding, one of our new cardiologists at the Ascot Cardiology Group, and we're going to discuss atrial fibrillation. Now, this is a condition that for many years has been managed rather conservatively. It's always difficult for us to know which patient should have a cardioversion and which patient should be managed with rate control, that's with drugs that slow the rate. Patricia, perhaps you could give us a bit more information about this.
Hi, Warwick. So traditionally, we tend to reserve selected patients for cardioversion rhythm control, usually in the younger patients who are more symptomatic with atrial fibrillation, those with LV impairment, and those who do not have severely dilated left atrium are able to maintain the rhythm after cardioversion.
Okay, so I understand there's some new information now that's just come out about which patients to treat in which way. Perhaps you could tell us a bit more about that.
Yeah, this is very exciting. There's a new trial called the Early Treatment of Atrial Fibrillation for Stroke Prevention trial, which is a randomized multi-center trial, has come out with results on patients randomized to early AF rhythm control versus the usual routine care to look at their composite cardiovascular mortality, stroke prevention, hospitalization for heart failure, and acute coronary syndrome. So in this trial, there are about 2,700 patients that's being randomized to rhythm control versus rate control. And rhythm control, they mostly used antiarrhythmic drugs such as amiodarone, sotalol, and flecainide, plus a number of drugs that's not available in New Zealand, but they're using elsewhere. And those who didn't keep the rhythm while on drugs, they had AF ablation versus the usual rate control.
Okay, so what did they find? What were the results of that trial?
So the primary outcome is the composite of either cardiovascular mortality, stroke events, and hospitalization for heart failure or acute coronary syndrome. There's also a secondary primary outcome where they looked at the total number of days with hospitalization over a whole year, and they found that the rhythm control group, there is a 28% reduction in cardiovascular mortality, as well as 35% reduction in stroke events, which is quite significant.
Okay, so what you're saying here then is that patients actually lived longer and did better if they could be got back into
Yes,
sinus rhythm.
Correct.
What sort of patients are we talking about? Are we talking about old people with AF? Are we talking about younger people? How do we select which person is appropriate for this type of treatment?
Yeah, so these patients are quite similar to our everyday practice. Median age is 70 years old with lots of comorbidities.
Yeah.
And the other main thing is the median duration since diagnosis is only 36 days. So these are newly diagnosed AF in an elderly group of patients, and the follow-up is about 5 years or so.
Okay, so I had another question to you. What was the dominant way that these patients were treated? Did most of them get these ablations, or did most of them just have drugs or tablets?
Yeah, so that's the other thing we need to be aware of. Majority of them had antiarrhythmic drugs, which we are aware that there are lots of side effects, and usually they should be initiated by a cardiologist. And in this group of it, they did look at the severe side effects related to antiarrhythmic drugs, which they found in the incidence of severe side effects is higher in the rhythm control group. However, it didn't really affect the total number of days being hospitalized, which seems to be the suggestion in the past that if you were on rhythm control drugs, you would need more hospitalization for that, and that is not the case.
Yeah, so what I take from this is, firstly, GPs are going to have to learn a little bit more about these antiarrhythmic drugs. So that's going to be the subject of one of our upcoming videos, which I hope you'll watch. And the second thing I take from this is that if you're in general practice and you find someone with atrial fibrillation that you think is of relatively recent onset, or even someone who's symptomatic with atrial fibrillation, that's really an indication for referral to a cardiologist. All those patients should be referred.
Correct. I think with this trial we are more confident and feel more favourable for readily favouring rhythm control strategy, even if the patient is over age 75, whereas in the past we would say if they're relatively asymptomatic, we can just use rate control strategy. But now we know we improve their mortality and morbidity with the results of this trial, which is very useful, I think.
Thank you, Patricia, because I think this trial is going to push us more towards trying to get patients into sinus rhythm. We hope to see all your patients with atrial fibrillation here at the Ascot Cardiology Group. Thanks.
All right, thank you, Warwick.